Hello and good afternoon. Thank you for joining us today for this webinar presentation offered by Aegis Sciences Corporation. Today's speakers are both clinical pharmacists and members of the Aegis clinical team, which includes a total of 8 clinical pharmacists with a variety of backgrounds and areas of expertise. Dr. Clary completed her Doctor of Pharmacy degree at Lipscomb University College of Pharmacy and her postgraduate residency training in community pharmacy. She has served as a preceptor for many pharmacy students on community, ambulatory care, and clinical rotations. She also serves on the admissions committee for Lipscomb University College of Pharmacy. Dr. Garland completed her Bachelor of Science in Biology and Master of Education in Curriculum Development and Instruction at Middle Tennessee State University. She earned her Doctor of Pharmacy degree from Belmont University College of Pharmacy and is completing the second year of a 2-year postgraduate fellowship in Drug Information and Toxicology at Aegis Sciences Corporation. Dr. Clary will kick off today's presentation with an overview of the Medication Monitoring Program Essentials tool, and then we will wrap up with an opportunity for you to ask questions to our presenters.
Thank you for that kind introduction. Aegis has created the Medication Monitoring Program Essentials document as a resource for providers who are considering incorporating drug testing into clinical practice. Let's start today's discussion by briefly defining what this document is and what it is not. What it is an information resource for developing a medication monitoring program. It provides an approach to perform initial evaluations and assess risk, baseline drug testing, mitigating risk via informed consent, patient education, signed treatment agreements, and continued patient reassessment. It provides tools for monitoring response and measuring results, and provides guidance for any possible modifications to treatment as the provider deems necessary. It also offers comparative drug and frequency guidelines, state and federal regulations as appropriate, and it's also an adjunct to clinical decision-making for more consistent patient care. What it is not, however, is an all-inclusive reference tool for constructing a medication monitoring protocol. It is not directive in recommending any specific risk assessment tools, testing frequencies, or other specific aspects of patient management, and it is not a substitute for the clinical judgment of the provider. Protocol development helps a medical practice plan, P-L-A-N. The P stands for promotes consistency. It standardizes multiple aspects of patient care to ensure proper application of provider judgment and medical necessity in clinical decision-making. Protocols also help lower risk. They establish checkpoints to ensure patient compliance with prescribed therapy, reduce risk of drug diversion, and monitor for risk of substance use disorder. Protocols also help apply evidence-based practices. They incorporate guideline recommendations for risk assessment, documentation, drug testing, and monitoring into routine patient care. And protocols also help narrate patient care planning. They provide a template for taking on new patients and modifying treatment as appropriate with established patients. Those of you listening today may have a variety of experiences with drug testing and your own perceptions of its value in clinical practice. As we discuss the various aspects of developing a medication monitoring protocol, one of the questions we answer is, does testing really matter? Each clinical setting has its own answers to this question, but consider these statistics that illustrate the nationally recognized crisis surrounding opioid and illicit drug use. According to the Centers for Disease Control and Prevention, drug overdoses were responsible for the death of 63,632 Americans in 2016, with nearly 2/3 involving use of a prescription or illicit opioid. An estimated 47.7 million persons in the United States aged 12 years and older used illicit drugs or misused prescription drugs in 2015. 1 in 4 patients managed with opioid therapy in primary care settings struggle with opioid use disorder. Many lives are represented in these statistics, which is a powerful first step to answering the question, does testing really matter? On a broader scale, why have a medication monitoring program? As we discussed during the introduction of today's topic, protocol development helps a medical practice plan. Providers may care for patients across multiple populations and therefore need to be familiar with multiple guidelines and state and federal regulations before implementing a medication monitoring program. Patients often do not voluntarily report noncompliance, prescription drug misuse, or illicit substance use, and some patients may even feign symptoms to obtain opioids for diversion, which necessitates objective assessments such as drug monitoring. One of the primary aspects of establishing a medication monitoring program is selecting tools and developing a method most appropriate to the client's practice for assessing patient risk. There are no definitive ways for a provider to accurately predict the risk of a patient simply by an instinctive feeling, a person's appearance, or even by socioeconomic status. With the increase in opioid overdoses and the potential for substance use disorder, it is becoming increasingly important for providers and health systems to better understand risk factors when evaluating patients. What do the guidelines and organizations have to say about developing a medication monitoring program or protocol? Several professional organizations have developed guidelines, recommendations, and positions addressing the incorporation of drug testing in the clinical management of patients. These guidelines recommend criteria by which a drug testing practice is implemented, and such criteria vary according to assessed patient risk and other factors. The American Society of Addiction Medicine describes periodic and unannounced drug testing as useful in monitoring adherence to the treatment plan, as well as in detecting the use of non-prescribed drugs. The American Society of Interventional Pain Physicians guidelines state that patients may be stratified into risk categories with proper assessment, with or without the use of formal assessment tools, along with monitoring through prescription drug monitoring program reports, urine drug testing, and simple psychological evaluation. As previously mentioned, clinicians should consult their state guidelines for state-specific recommendations regarding assessment or treatment of patients based on risk. At this time, Dr. Garland will discuss specific information on specimen types, testing methodologies, and considerations for impact on patient care. Dr. Garland?
Thank you, Dr. Clary. Many specimen types are available for drug testing, each with advantages and considerations. Specimen types include urine, oral fluid, blood, breath, hair, nails, and sweat. Each specimen type presents unique insight regarding medication use over time, including the type of information that may be obtained, ease of collection, degree of invasiveness, and analytical and interpretive considerations. As you can see, the focus here is on urine, oral fluid, and blood, as these are the specimen types tested at Aegis. However, it is important for a clinician to research the optimal specimen type most suitable for a clinical situation to provide appropriate patient care. Oral fluid and blood allow for an observed collection. However, oral fluid samples may be subject to tampering. Blood and oral fluid have a shorter period of detection than urine, in which drugs may be detectable up to 5 times longer. In reviewing the key advantages of urine, it is an easy sample to collect for most patients and is less invasive than drawing blood or holding a swab in the oral cavity. It is important to note for consideration, once again, the longer period of detection for drugs and their metabolites afforded by testing urine. Collecting urine also allows for the detection of several drug metabolites that would not be detectable in oral fluid or blood due to the drug disposition in those specimens. Also, urine requires minimal preparation for analysis compared to other specimen types. It is for these reasons urine remains the gold standard for drug use monitoring and is the most extensively used specimen for drug testing. Another point of consideration for clinicians in the drug testing process is what method will be used to test the collected specimens. Presumptive methods, such as immunoassay testing or point-of-care testing that a clinician may perform in their clinic, function based on the binding of a drug to the test antibody. With this type of testing, cross-reacting compounds may result in a false positive result. Conversely, a lack of cross-reactivity within a particular class of drugs may result in a false negative result. The extent of cross-reactivity across a drug class or to other cross-reacting compounds may vary depending on the immunoassay used. For instance, pseudoephedrine may have cross-reactivity with methamphetamine, resulting in a false positive result. While presumptive methods are typically rapid, less expensive, and do not require extensive training to perform, the results are not definitive and are, therefore, subject to false positive and false negative results. In contrast, definitive methods identify compounds based on their unique molecular fingerprint. Chromatography separates compounds, and mass spectrometry identifies the presence of specific analytes based on the unique molecular mass and ion fragmentation pattern of each substance. Definitive methods have a reduced risk of false positives and identify drugs and metabolites missed by presumptive methods. While definitive testing takes more time to complete and requires specially trained scientists to perform the testing, it provides clinicians with clinical confidence in the results. According to multiple guidelines and organizational statements, all unexpected presumptive-based tests are recommended to undergo definitive testing. In completing definitive drug testing, the results empower the provider with further clinical information needed to make patient care decisions. Before making a clinical decision, consider drug testing results within the context of the patient's clinical history, current presentation, and any other relevant patient information. Consultation with a clinical toxicologist may also aid with interpreting definitive drug testing results. This information is essentially a toolbox for clinicians to explore as they consider implementing a protocol in their practice. The content is not all-inclusive and in no way supersedes the clinical judgment of the provider. These topics are merely prompts to encourage further reading and study before determining which protocol elements will be most pertinent to a given practice setting. At this time, Dr. Clary will expound upon the elements for consideration when creating a protocol.
Thank you, Dr. Garland. Again, revisiting some of our opening points when starting today's discussion, developing a medication monitoring protocol promotes consistency. Managing patients requiring treatment with controlled substances may be more safely accomplished by following a consistent care model. Drug testing can be considered as a part of an overall medication monitoring protocol with various additional elements as appropriate for the patient population. The approach to patient care will differ substantially based on certain conditions and patient factors, which may warrant referral and/or reference to entirely different guidelines and standards of care. Such patients may require more intensive or immediate care, and providers should be vigilant for any signs and symptoms of conditions that may warrant this level of care. Children, adolescents, women who are or desiring to become pregnant, or patients who have psychiatric diagnoses such as substance use disorder may require additional elements to successfully develop an appropriately customized medication monitoring protocol beyond those described in today's presentation. Patient assessment lays the framework by which care options are identified and delivered. This framework can also provide initial and continuous guidance in the care plan decision-making process. Examples of items that may be utilized are listed here, and this list is by no means all-inclusive. Providers may use any other tools that they deem fit for assessing their patients. The risk assessment process is multifactorial, and the weight of each factor is determined according to the clinical judgment of the treating provider. As a reminder, the acronym PDMP stands for Prescription Drug Monitoring Program, and the results would be the results of a query to your state's database or neighboring states, depending on your location and state law. Various risk assessment tools may be utilized by prescribers during the initial screening and monitoring processes. According to the CDC, clinical evidence review found that currently available risk stratification tools show insufficient accuracy for classification of patients as at low or high risk for abuse or misuse. Multiple guidelines have not recommended any one specific risk assessment tool, but they do encourage clinicians to use one or more of these tools in the overall assessment process. Clinicians should not overestimate the sensitivity and specificity of available risk assessment tools to determine the long-term risk associated with opioid therapy. Assigning a level of risk to a patient is subjective, based on clinical judgment, and encompasses a broader view of the patient than the output of a formal risk assessment tool. Examples of formal patient assessment tools may be reviewed in the Medication Monitoring Program Essentials document. While basic protocols and care plans require medical record documentation, especially as services rendered increase, it is of critical importance when a service is denied by a payer. Documentation must include reasoning as to why a service is ordered or requested, and should include anticipated management decisions based on anticipated test results. The same documentation thought process is important to consider when utilizing drug testing services. When considering the clinical value of drug testing and anticipating which testing methodology and frequency is appropriate to provide care for the patient, it is important that sufficient medical record documentation is provided. Numerous guidelines, professional organizations, and regulatory bodies suggest that assessment of patient risk and documentation processes be conducted in a systematic fashion. The Federation of State Medical Boards provides a general practice reminder that all patient assessment, monitoring activities, and referrals should be thoroughly documented in the patient chart on an ongoing basis. Records should remain current and be maintained in a readily accessible manner for review. Some examples of documentation recommendations from the Federation of State Medical Boards are listed on this slide. Please keep in mind that this is not an all-inclusive list, and state guidelines may have additional requirements. Other resources that providers may refer to for further guidance on documentation standards include the Veterans Affairs and the Department of Defense, American Pain Society, and the American Society of Interventional Pain Physicians guidelines, as well as guidelines pertinent to the care of their specific patient population. Of note, the last example listed on the slide, medical necessity, is defined as accepted healthcare services by accepted healthcare professionals that are appropriate for the evaluation and treatment of illness, disease, or injury that is consistent with applicable standard of care. Centers for Medicare and Medicaid Services, or CMS, provides a specific definition under the Social Security Act, which states, "No Medicare payment shall be made for items or services that are not reasonable and necessary for the diagnosis of treatment of illness or injury, or to improve the functioning of a malformed body member." The reasonable and necessary standard is founded on evidence-based scientific data, frequently available as clinical practice guidelines, published by professional societies or organizations that should be individualized to the specific needs of a patient. If maintained, the items listed here are useful in the support of patient education. Such items may also assist in guiding clinical management based on patient-physician developed treatment goals. Consent forms, treatment agreements, risk documentation tools, and documentation of regular monitoring of patient outcomes and behaviors are examples of elements that promote consistency, lower risk, apply evidence-based practices, and narrate patient care planning. Consent is essential for a proper patient care relationship between prescriber and patient, as well as for securing third-party payment for drug testing. Several resources address the role of informed consent in treatment agreements. The American Pain Society and the American Academy of Pain Medicine guidelines recommend obtaining informed consent at the start of therapy and an ongoing conversation with the patient regarding treatment goals, potential risks, and alternative therapies. The Veterans Affairs and the Department of Defense guidelines further recommend that this process be patient-centered. According to the Federation of State Medical Boards, informed consent may address multiple items, such as those listed here, to ensure the patient fully understands their medications, the monitoring process, and the management of their care. Whether patients are beginning treatment with controlled substances for the first time or establishing as a new patient with previous treatment experience, these topics provide opportunities for the provider to educate and have a bidirectional conversation between the provider and patient. Treatment agreements address the responsibilities of the prescriber and patient, including the patient's agreement to random drug testing, which is ordered based upon the clinical judgment of the provider. Multiple guidelines discuss the use of treatment agreements as an ongoing monitoring tool to assess the patient's compliance with treatment and potential change in risk status. The Federation of State Medical Boards strongly recommends that treatment agreements include treatment goals such as pain management, restoration of function, and safety, the patient's responsibility for safe medication use, including taking no more medication than prescribed, the dangers of combined use with alcohol, cannabis, or other substances like benzodiazepines, unless closely monitored by the prescriber, secure storage and safe disposal of medications, patient responsibilities such as obtaining prescribed opioids from only one clinician or practice, filling prescriptions at only one pharmacy, the patient's agreement to periodic drug testing, the clinician's responsibility to be available or to have a covering clinician available to care for unforeseen problems and to prescribe scheduled refills. As an example, we have included the treatment agreement outlined in the Veterans Affairs and the Department of Defense Clinical Practice Guideline for Opioid Therapy for Chronic Pain as Appendix A in the Medication Monitoring Program Essentials document. As a pharmacist, I am especially an advocate of thorough patient education. Thoroughly reviewing the informed consent and treatment agreement process with patients helps facilitate understanding of their new treatment plan. For some patients, the medications being prescribed may be entirely new, and such strict expectations regarding behavior and monitoring may seem punitive and invasive apart from thorough patient education. The teach-back method is a very valuable tool in many clinical settings and is one often employed by pharmacists when counseling patients on new medications. Providers may ask the patient to repeat and summarize the instruction given to them. If they are unable to do so, the provider may help fill in gaps in their understanding until they can restate the information appropriately. Materials provided to patients should be in an appropriate language and reading level to facilitate their understanding. The National Institute on Drug Abuse has materials available online to assist patients with low literacy. Now Dr. Garland will discuss the ongoing and multifactorial process of patient monitoring and measuring results of various assessments and interventions. Dr. Garland?
Thank you, Dr. Clary. Once a patient has been placed on chronic medication therapy, comprehensive monitoring practices should be in place based on patient risk of substance abuse, misuse, or addiction, as previously determined through the use of multiple assessment techniques. Although there is insufficient evidence for specific recommendations about how to monitor patients on chronic medication therapy, there is general agreement to include items such as assessment and documentation of pain severity and functional ability, progress toward achieving therapeutic goals, presence of adverse effects, and clinical assessment for the presence of aberrant drug-related behaviors, substance use, and psychological issues. A A table is included in the Medication Monitoring Program Essentials document that provides an overview of elements of ongoing patient monitoring, including references from guidelines and organizational statements. Urine drug testing is addressed by guidelines and organizational statements as a component of continuous monitoring. Since this activity is a separate billable service with potential financial and treatment impacts on the patient, clinicians may consider the potential value of information learned from drug testing and its role in safe prescribing. This information may not only indicate adherence and substance use, but also provide insight into reasons for intolerance to prescribed therapy, reduced response, or dose escalation requirements. For example, metabolism patterns observed in urine drug testing may help reveal potential pharmacokinetic variability, which can be further investigated. We are often asked about the appropriate frequency with which patients should be tested. As noted on the slide, the frequency with which drug testing may be deemed appropriate is associated with great variation within the guidelines and is heavily dependent on the provider's clinical judgment, as well as relevant payer considerations. During the evaluation of an existing or development of a new medication monitoring protocol, it is important to evaluate payer mix and expectations regarding laboratory services. The payer requirements for coverage among a practice's most frequent insurance payers for a given service or services can be compared to show CPT codes for the services rendered, the rate of reimbursement, the level of service in terms of presumptive versus definitive testing, the number of services allowed per week, month, or year, documentation and signature requirements by the payer if they are different from the Centers for Medicare and Medicaid Services, and any special requirements for a given payer. A payer coverage policy example titled Controlled Substance Monitoring and Drugs of Abuse Testing from a Medicare Administrative Contractor, Palmetto GBA, may be found in Appendix B of the Medication Monitoring Program Essentials document. The table shown here is included in the Medication Monitoring Program Essentials document and lists frequency details described within various guidelines and in organizational statements. The frequency selected by a provider may change during the course of patient treatment, as risk assessment is continuous and ongoing. Providers should use their clinical judgment in determining the proper frequency for testing their patients. This table is also included in the Medication Monitoring Program Essentials document and provides recommendations from various guidelines and organizations regarding the selection of drugs for which to test. Providers may choose to test for any drugs they deem clinically necessary for monitoring the patient's treatment. The selection of drugs may also increase or decrease over time based on the provider's clinical judgment and any current prescriptions the patient is taking. Patient behaviors and assessed risk may also impact drug selection when ordering testing and when determining frequency of testing. As a reminder, drug testing should not be relied upon as the sole determinant of a patient's substance use. Drug testing should be supplemented by a conversation with the patient concerning his or her medication use. The patient's self-report, along with other assessment and monitoring methods, provides additional clinically relevant information. The American Academy of Family Physicians also recommends clinicians request definitive testing when presumptive results differ from patient-recorded use, among other clinical scenarios as listed on the slide. The clinical value of definitive testing in these scenarios has been described previously in today's presentation. According to the Federation of State Medical Boards, drug test results suggesting opioid misuse should be discussed with the patient with a positive, supportive approach to build a stronger patient and physician relationship to encourage healthy behaviors. The organization also recommends these interactions, as well as test results, are documented in the patient's medical record Furthermore, changes to prescribed medications and clinical decisions should not be based on one abnormal result, but rather based on a review of all available monitoring results. Due to the complexities involved in the interpretation of drug testing results and the potential impact on the patient, the Federation of State Medical Boards suggests clinicians review significant or unexpected results with a laboratory toxicologist or clinical pathologist. At this time, Dr. Clary will provide some closing comments to conclude today's presentation.
Thank you, Dr. Garland. In our time together today, we have reviewed key areas of consideration for constructing a medication monitoring protocol. Those of you on the call today have access to a great starting point for further research. As you read the pages of Aegis's Medication Monitoring Program Essentials, you may find that your research will expand to the clinical guidelines specific to your area of practice and state laws specific to your location, among other sources. Our goal is to provide you with as much information as possible to combine objective tools with your own clinical judgment to arrive at the most appropriate care decisions for your patients. The core of what we do at Aegis is helping clinicians make better decisions, and providing this educational material is one way we strive to meet this objective.